Uh, can we have
No,
discussion?
sir, there is no any question.
So we have discussion at the end.
Okay. So thank you very much. Thank you, sir, for this wonderful lecture. Now we are moving to another lecture that is by Dr. Itmar Raz. Dr. Itmar Raz is from the Israel. He's a professor and received his medical degree from the Hadash Hebrew United Medical School in Jerusalem in 1980. He's a board director, board certified in the internal medicine. He's a full professor of internal medicine and was the head of the diabetes unit at the Hadash University Hospital from the 2000 to 2015. He is currently serving as the head of the Israeli National Council of Diabetes and is the initiator and leader of the National Diabetes Prevention Care Plan in the Israel. In addition, he is the president of DCure, a non-profit organization that promotes and funds scientific research in the Israel for finding a cure and better treatment for diabetes. In the past, he has served as the president of the Israel Diabetic Association from 1992 to 2004, and he has holds various editorial positions in the 8 diabetes-related international journals and over more than 4,400 publications. So, not taking much of your time, I invite sir for his lecture on the need for new guidelines on the diabetes management. Over to you, sir.
Thank you, Dr. Fatal. Thank you very much. I also want to thank Professor Banshi for inviting me to this very important meeting. And I want to discuss together with you today, the question is whether we need new guidelines in diabetes. And this is my disclosure. This is a wonderful review that was written by the best people in the United States, 34 people, they're discussing the need for new guidelines in diabetes. It was published in not a very famous journal, but I suggest each one of you to read this wonderful review. But I still have questions regarding this review. The review talks about nutrition and physical activity, treatment of obesity, cardiovascular risk factor, hypoglycemia, treatment to prevent and treat diabetes complication. However, the guidelines do not look directly at the very old people, at those who are 65 or 75 years old or even more. And I want to remind you that 70 to 80% of our patients are patients who are older than 65 years old. So we have to ask ourselves whether these new guidelines are enough and whether they are good also for the very old diabetic patient. So let's talk about nutrition. We all know that Mediterranean nutrition is a very...
Sorry to interrupt, sir.
Yes?
Can you make it in the slideshow mode?
Can I?
Yeah, your presentation is not in the slideshow mode, sir. Can you make it in the full screen?
It's not a full screen?
Not yet, sir.
Okay, I'll try to do it. 1 minute. About a healthy lifestyle. So we're well aware about the need for Mediterranean or Mediterranean-like food. However, very important in the old people is food high in protein that was shown to be also a very healthy food when you increase the percent of protein from 18% to 20%. These are new data. New data also show that eating in breaks can reduce the risk for cardiovascular events, and most probably also increase life expectancy. Recently, also sugars and sweeteners have shown to be deleterious in patients with type 2 diabetes, increasing insulin resistance and increasing the risk of the patient, and also high protein intake. When we talk about exercise, recently several studies have demonstrated that in people older than 60, you don't need necessarily to do 150 minutes of aerobics, which is the best. What's important is to do every day strength exercise of about 10 to 15 minutes. That will be the best way to keep your muscles. So these are the sources that I brought it from. The importance of protein source for muscle health, mainly in elderly type 2 diabetic patients, because in type 2 diabetic patients, hyperglycemia causes reduction in the amount and reduction in the effect of the mitochondria, and this can be overcome by exercise, and this can be overcome by good blood glucose control. Just to show you the issue of fasting that will mimic a diet in prevention of diabetes and cardiovascular disease, as I mentioned. And this study recently published in Cell demonstrating that sweeteners can be as deleterious as glucose when it comes to insulin resistance in human beings. Now, what about obesity? In obesity, we talk about prevention in the youth, but when we talk about old people, the question is, should we aim at the healthy weight, which is 25 to 27 BMI in the Caucasian, and even a little bit less in Indian people? What about weight maintenance? And what about the issue of gastric bypass? Now, it's very important to remember that when you get older, at the age of 60, you already lost about 40% of your muscle, and you already increased about 30% in your abdominal fat. So we need to do cardio fitness, but we need to treat patients in a way that will increase their muscle and decrease their body fat. However, in the last 10 years, the issue of obesity paradox came out, because it was shown that people at the age of 65 or more who weigh or whose BMI is more than 30 are in a way seem to be healthier than those with a healthy weight of 25 to 27 or 27 to 30, which is overweight. So the big question is, if we have a patient with BMI 30 to 35, or in India, it can be 27 to 30, should we aim to reduce his weight? And different studies have demonstrated that it is, that actually there are 16 studies to show that in the old patient with BMI above 30 in the Caucasian, there will still be a positive effect in reducing weight. And what you can see here, that young patient, 35 to 50, when you reduce when they're overweight, when they have a very high, when their BMI is 40, their cardiovascular and longevity is shorter. Similarly, in patients up to the age of 69, however, even patients who are above the age of 69 will still benefit from reduction in the weight to BMI of about 27 in the Caucasian. But the big question is, these studies actually show that the lower your weight is, the better. But the question is, what about treating patients who are obese with a drug that reduce weight? And here I want to show you the study that I have actually led together with a TIMI group in Harvard, and this is the DECLARE study. And what we have demonstrated is that when we reduce weight at any age, let's look at 75 or more, and you can see that with dapagliflozin, we reduce weight similarly to what we reduce in those 65 or less. And let's see what happened. What happened was that at the very old people, you can see that the beneficial effect on the kidney and on the heart are actually similar to those that you can see in younger patients. However, the big question is, what about deleterious effect? What about side effect? And what you can see is that if you look at side effect, for example, major hypoglycemia, you can see that there are less major hypoglycemia and the dapagliflozin in those 75 or more, or those of 65 or more, even better than those that less than 65. If you look at diabetic ketoacidosis, you can see that the risk is similar when you are 65 to 75, or even those who are above 75, you don't actually see a difference in the risk of ketoacidosis in those patients. And all the other risk factors that comes with reduction of weight do not seem to be more deleterious in the very old than they are in the very young. So since I missed time and I don't want to go over it, pre-diabetes is a very important issue to discuss. However, I will leave it. I will not go to the drugs on pre-diabetes, but we have to remember that pre-diabetes put you to cardiovascular risk and renal risk, and it's not only diabetes that enhance this thing. Now, another thing is, what should be the aim of A1C? And you can see here that they talk about normalizing blood glucose, but trying to be up to 7.5. And here I want to say that as long as it's not deleterious, I think we should aim to hemoglobin A1C less than 7 and even normalize hemoglobin A1C at any age of the patient, mainly if you use those drugs that are not drugs that will cause hypoglycemia. Now, what about hyperglycemia? Why is it so important to aim to normal glycemia also at the very old? Sure, the target is depending on the treatment. If you give insulin, if you give hypoglycemic drug, you should be more careful at the age, and you should aim to less than 8. But in general, when you use the usual drug, you should aim to normalize blood glucose level as much as possible, even in the old population, using these 3 drugs, metformin, SGLT2, and GLP-1RA, or any other drug that will not cause hypoglycemia. And this is because it was shown recently that in the old people, the older they are, you need to be normal glycemic in order to keep their muscles and to keep their brain. Both of them need a great effect of the mitochondria that could be reduced even when your blood glucose level or when your A1C is above 7. What about hypercholesterolemia? Statin treatment seems to be the goal at any age. Many times combined treatment will be very, very important. The PCSK9 inhibitor, very important. And the target should be, if possible, less than 70. And the other thing is that the lower, the better. And this we learned mainly from the PCSK9 that have demonstrated a great reduction when it's added to statin. And you can see the effect of this drug on the level of cholesterol, as you're well aware. And as you know, this was shown to reduce MACE. And not only this was shown to reduce mainly cardiovascular events. And recently, there was another paper demonstrating that reduction cholesterol, LDL cholesterol, from 49 to 22 still gave a beneficial effect. So I would tend to agree with the guidelines that I just mentioned to you at the beginning, that we should aim to LDL of below 50 at every diabetic patient when this is easy to use, although here they talk about going to less than 50, mainly in those who have what they call extreme disease, which means diabetes and atherosclerotic disease, or can be even and very extreme, those with short life expectancy because of it, and you should go and learn. But what you should learn when you have an LDL in a patient, which is 25, 30, don't reduce drug. This is the best LDL. And the way today is to say that lower is always the better, what Brownwell used to say in the past. Moreover, statins have advantage, and I just bring you one, known to be an anti-inflammatory drug. And recently it was shown that if you look at patients who are under statin, you will find that about 70 to 80% less of those people will have high anti-nuclear antibody, demonstrating that statin can also prevent autoimmune events in patients. What about hypertension? The goal in the study that in the paper I just mentioned, talk about lower than 120 to 80 because it was shown not only in diabetic but also in diabetic that 120 under 80 are better than 130 under 80, and this is in spite of the finding in Accord. A very important thing in the old patient is the issue of preventing cognitive dysfunction. And the question is, how do we treat them? Or how do we know that a patient has cognitive deterioration? Because it was found recently that the earlier you treat, the better. And you can see here what is suggested to do at every clinic, a mini mental state, the clock drawing test, and different physical tests to show that your patient is still with a good cognitive. Now, what happened in those patients who do not have or who seems to have deterioration in cognition? So there are several studies to demonstrate that you can do something, mainly if you improve oxygenation of the brain. And one of them is hyperbaric oxygen therapy. This was done in Israel, and it was demonstrated that using hyperbaric way, you can actually improve patients who have early cognitive deterioration, who on a daily basis do not seem to have deterioration. It was demonstrated that you improve their cognitive function, and not only this, you improve or increase the telomere size, which is very, very important for patient longevity. Now, I'm not going to go over all the complications because I already took my time. But what I want to tell you is when you go to this guideline, you will find several suggestions for new guidelines in the treatment of different complications, including Enfield and Nash. But I will not go into it. The issue is that today we need new guidelines. Now, when we talk about new guidelines, we want to talk about digital therapy, and part of this digital therapy, the way to follow patients, the way to treat patients from way above, and those are already here. There are quite many that are now being developed, and today, actually, when we talk about artificial pancreas, there are ways that were being done by patients to have artificial pancreas in nearly every patient with a very minimal expenses. This is not yet assured by the FDA, but it works wonderfully. I can tell you that in my country, we have now about 4,000 type 1 diabetic patients who are using their own artificial pancreas, using the data that we have with us today. So with this, I want to summarize. I want to say a big thank you. The most important thing today is to try and think, what can we do, mainly in the elderly, which are 70 to 80% of our diabetic patients, to improve their cardiovascular outcome, to improve their microvascular outcome, to improve their brain, their muscle, and everything which is of great importance for their everyday life. Thank you very much.
Thank you so much, Dr. Itmar Das, for a great elaboration on diabetes and also pre-diabetes. For a great information on this developing, we can have new guidelines. We'll have discussion at the end of this session. So please, sir, be seated till that.
Yes, sure.
Speakers, please invite our chairpersons. Please invite our next speaker.
Yes. So we are really fortunate to have with us Professor Rakesh Sahai, who is professor and head of endocrinology at Osmania